you can check further definition from the link given. So UHC is covered under a lot of the global as well as our national and regional policies. So here, the demonstrating where it's covered in the Sustainable Development Goals, the UN Sustainable Development Goals that replace the MDGs. And so universal healthcare can fall under many of these goals. Good health and well-being, that's the third one. That when people are healthy, they then can work and there's economic growth. The eighth one, it reduces inequalities, especially gender inequalities. And it gives an opportunity for partnership because for attainment of the Sustainable Development Goals, and indeed UHC, partnerships are key in facilitating that. So one of the things that is key when you're thinking about UHC is a unique identifier. And why do we need a unique identifier with UHC? It applies at multiple levels. At an individual level, we need a unique patient identifier for correct attribution. That means when we identify and say we're offering services to person X, then it indeed needs to be that person X who is receiving those services. If we're getting, if you're being sent to the lab or to imaging, that then your results are actually yours and not someone else's. And then also for follow-up purposes, especially where you're talking about longitudinal services, and this applies not just to curative services, even preventive rehabilitative services, including maternal and child health. So where if you're having a lady coming back several times for delivery, then being able to follow that person up longitudinally over their lifetime. Then the third one is self-transfer, and this is critical if we are going to achieve UHC, in the sense that patients or clients really need to be able to move organically, freely within the health service system, such that if for example, you receive your services in Mombasa and when you're due for your next service, you find yourself in Nakuru, it shouldn't be a problem that you wouldn't have to wait till you get back to Mombasa, but that you can actually be seen and your records are retrieved and you get the services that you require. So that alludes to the need for a unique patient identifier at an individual level. At the facility level, again, for efficiency purposes, especially when it comes to planning, think about a clinic where you are running, say, for example, a physiotherapy clinic, and you want to know how many clients you're expecting that day. And so that helps you in terms of planning for staffing for that day, for example, in terms of getting your space and your equipment ready and all that. And that promotes efficiency in terms of how the clinic runs. And then at the facility level, it also promotes data-driven planning, meaning if you're going to be planning for things like leave for your staff or procurement of staff, of commodities, then you actually are very clear the actual number of clients or patients you're serving. At a program level, the need for a unique patient identifier cannot be overemphasized. Think about a program like the HIV program, for example, data deduplication, where if someone comes and presents as says that their names are XYZ, and then they go to the next facility and say their name is ABC, and they present for testing at the same time in both instances, sorry. So that would help. It helps if you have a unique identifier that can be able to then tell you, no, this is the same person, even if they told you that here they were ABC and there they were XYZ. It's actually the same person. And then you actually get to know. So when we say we have X number of people who are HIV infected in this or who are HIV positive in this region, then that's an actual true number of the people that represents. Correct classification, think about, when you talk about new clients versus revisits, someone comes here today and poses as a new client and then goes to another facility next week and poses as a new client. If you're not able to differentiate or to identify that these two are actually the same, one and the same person, then you would misclassify them. And that does interfere with how much you can then use program data to, make inference and even use it for things like case-based surveillance, where if you have a unique identifier and you can clearly say that this is one person, then you can be able to engage in things like case-based surveillance. It also helps with actual determination of coverage. So if you're thinking about something like immunization, where we want to know when we say that measles one coverage is about 69%, is that an actual true number, or is it that it could be lower because patients have received the measles vaccine but were not identified as having done so? And then at the national or at a governance level, depending on how you're viewing UHC, a unique identifier helps with accountability, because when you say you've served X number of clients, you need to be sure that that's the actual number of people that have been served. It helps with curbing fraud, for example, and this you see commonly even with private insurances currently. When you present yourself to receive a service, they have to verify that you are who you say you are. And then also at a governance level, think about strategic planning. So when you say your services this month, you have offered promotive services to 30% of your population, and you want to move that up to 50%. Think the indicators that have been set forth by governing bodies, including WHO, in terms of monitoring UHC, attainment of UHC, then you would need to be clear about the number of clients that you're actually serving. So a unique identifier, here I call it a unique patient identifier. You'll forgive me, it's just typical for me to think patient, but it's actually a unique client identifier is critical if we're going to support UHC to be achieved in the manner in which it was envisioned. So currently, I picked this picture from somewhere on, it was a Star newspaper, and this was around the time when Huduma number people were enrolling for Huduma number. And as you can see, we have quite a number of identifiers, very, very many. And so it is, and then we have one new one, NIMS or Huduma number. So there's been all these questions about, so which of these should we use? What should we adapt? Why, will this one number replace all the rest that have already been issued? I really don't have an answer. I'm hoping some of the panelists we invited will talk to us more about this, but I do I am aware that at a policy level, there's a lot of discussion going on about e-citizenship and how to serve clients centrally, holistically, not just health, but looking at them from all aspects of the services that citizenry need, and how then the health sector specifically can tap into this e-citizen approach to then be able to get a unique identifier that cuts across all health services. I'd urge you to read the Huduma bill. I'm not sure if it's been passed yet into an act, but it's important that one familiarizes themselves with what will or will not be possible without the Huduma number moving forward. One of those is access to universal healthcare services. It would not be possible to access those without having a Huduma number. So switching gears, talk about what is a good identifier. One thing, there are multiple characteristics that it needs to have. One is that it needs to maintain the privacy of the individual, meaning should that data be accessed by someone else, whether intentionally or accidentally, that person does not get whoever accesses the information doesn't get to know who that identifies. It needs to be global or universal. Everyone, gets access to one. And here, think about, like the national ID, for example, is not very global because one, you have to be over 18 to have one, and then I understand there are people who can get along in life without having a unique, having a national ID. So one can survive without having one. So it's not everyone has access to one. It needs to be secure. That data, the unique identifier needs to be secure, just like your ATM is secured by your PIN. Then the unique identifier needs to also be secured in a certain manner. It needs to be able to be integrated into medical record systems. So here, again, thinking about it from a UHC perspective, from a health perspective, that number needs to be in a manner that it can then be used to link what we call your shared health record, so that if you move from one facility to another, then your records can be accessed, say if they're on an EMR system. And last but not least, it needs to be based on personal immutable properties. By personal immutable properties, I mean it needs to be something that doesn't necessarily just refer to what you say or what you have, but actually who you are. So I think that's what I was trying to allude to. It identifies you by who you are, as opposed to what you know or what you say or what you possess. Might I add that I think a good identifier needs to be feasible in the sense that it needs to be something that can be implemented feasibly. That means it's affordable. We have the infrastructure as well as the software required to achieve it. And it also needs to be acceptable, such that people will not reject, as we're seeing with some people and the Huduma number, where people are pushing back against, another card, another number, and all that. So specifically, biometrics is a unique client or unique patient identifier. The positives of this is that it authenticates identity. It says, if you say you're person X and your fingerprints say otherwise, then you are not person X. So it authenticates who you really are. It's independent of the patient in the sense that it doesn't matter what you say or who you are when you press your palm, or if we scan your face or your fingerprint. That's all we need. And so it would even be able to identify you should you be in a comatose state. It's largely mutable. Biometrics are largely mutable, meaning they don't change with time, largely. Again, not that all of them don't change. Some do with time and tear and wear, but most of them don't. The downside of biometrics is that they are expensive in terms of infrastructural support. One has to think about interoperability in the sense that you have to, as I said, for it to make sense from a UHC perspective, it needs to be interoperable with your medical record systems or your health information systems. And then there's a question of acceptability. There's been a lot of, back and forth discussion about taking people's fingerprints, taking people's retinal scans, facial scans, and is that acceptable? So when you're thinking about biometrics in terms of a unique patient identifier, we're thinking about a scenario as shown where you have your biometric templates, be it your fingerprints, be it your iris scans or your retinal scans, and then that's combined with something else that we used to that you've used to register. So be it your birth certificate number or anyway, some other text-based algorithm combined with that. And so that's housed in a central MPI, Master Patient Index. And then depending on what is needed or which of these services you're seeking, then they can tap into this central place and get the piece of information that they require. So if you looking at it from an education perspective or a social security perspective, even the banks, they tap into that to verify your identity. So that's how the biometric template would be combined with another civil registration number. So for those who are conversant with the IPRS system, that's what we currently use for authenticating identity for official purposes, say for banks or immigration services. This is sort of what they have minus the biometric. Actually, they do have the biometric piece because of your fingerprints for those people who have IDs. So this is the vision for how a unique patient identifier or based on a master patient index is supposed to work moving forward. And this is actually covered in the Huduma Act, the Huduma Bill. So with that, I want to use an example of HIV as a program to describe the work we did looking at feasibility and acceptability of a biometric identification system using an iris recognition system for routine HIV services in Kenya. So currently, a lot of biometrics are actually in use in health services, but most of them are used either for research purposes, as well as other services like conditional cash transfers. So in limited settings, in other words. But here we try to integrate this in routine services, HIV services in Kenya. And why we chose HIV is because, well, one, the coverage indicators are very well defined. And so you could apply this to any other disease setting or any other health service setting, really. So with HIV, there's a target, UNAIDS targets for 90. Then I think now we've revised this to 95% of all people, being aware of their status, receiving their drugs, and of those receiving their drugs, 90% having viral suppression. And then the continuum of care with HIV is also well defined. Once you tested positive, then you need to link to care. And once you've linked to care, you need to initiate ART. Now it is universal regardless of your CD4 count. And then once you've started your treatment, then you receive all the support that you need, including adherent support to achieve undetectable viral loads. So unique patient identifier, as you can see, would be important for all these sections so that we can be able to track a patient, whether they've, if they've turned positive, then have they linked to care, have they started ART, and are they actually suppressed? So one of the main challenges in HIV is what I was talking about earlier in terms of problems with duplication. This is a study that was done in Ampath not too long ago, where they looked at people who had not engaged in care at the time. So this was, they were doing a home-based counseling and testing. And when they did that, the number of people who had a non-linkage to care status was about 81%. That's a very huge proportion. But then when they used various matching methods back at Ampath, looking at their records, they actually realized that 81% is a fairly small proportion. It's actually 12% who are truly not linked to care. So again, without a unique patient identifier, it's difficult to actually, say that this is the actual number of people you have in care or who you do not have in care. And another interesting proportion here to look at is the yellow proportion, the 16%, who were linked to care prior to the home-based testing. And while they were doing this home-based testing, they were actually asking people, have you ever tested for HIV before? And so the person would say no, or within the year as per the guidelines. And the person would, if the person responded in the negative, then they would proceed to test them again. So you see classification, we're saying we have X number of people who have not tested, are not newly tested within a certain time. They're actually very few. And this is not a problem just in Kenya. Again, this happened in King County. This is in Seattle, where case investigation, that's trying to follow up case by case using a lot of text-based algorithm matches. So your names, your dates of birth, trying to match that with algorithms. It reduced those thought to have fallen out of care from 27% to about 16%. So here in our setting, we were in 4 places: Kisumu Referral Hospital, Kombewa Sub-County Hospital, KMH, and Kiambu, just within the regular CCC setting. And we were actually doing this with people who were testing positive at the time. That's at their VCT and other HTC points, HIV testing and counseling points. And then also for those people who are already known and engaged in care, so people who are attending their regular CCC clinics. Then we did this in February, between February 15 and 2016. And so we would collect the information based on the national HTC intake form. We didn't really create another form, we just used what the national government has prescribed. And then after you, we identified your demographics, your testing history and all that, then that's the camera that we were using to scan your irises. The plural of iris is debatable. So we would scan your iris like that, and then that's what would happen. We had a software developed by this company called iRespond, which we would link to the camera. So the camera gives you the image, as you can see, and then that's fed into the system, and then that generates that 12-digit number that you can see. That's a fairly random 12-digit number. And then that becomes your unique ID. So were you to come again, so for example, those who are already in care and came for multiple visits within that study period, you would do the same thing, but starting from here, where you just scan, we wouldn't recollect your information, and then it would search the database and pick up your unique ID, and then we would use that, feed it back into your form as you proceeded to see the clinician or receive the services that you came for at CCC. Also, if you were enrolled at a VCT and you linked to care in the same facility, when you presented at the same facility and scanned, it would be able to give you your ideas you had been given at the VCT. I get asked this question a lot, why the iris? We chose the iris because while it's formed pretty early, remember I talked about universal access. So for as long as a child is above 10 months of age, well, even before that, they do have irises, but at the time, when they're younger than that, the iris morphologically can change, but by 10 months, it's pretty done. And then the formation has no genetic penetrance, meaning you can have identical twins, but they cannot have the same iris stria, the pattern of the iris stria. So the iris is the black part of the eye, or not the black part, the brown part, depending on which part of the world you're from. Most of us have the brown part being the iris. Then there's minimal physical contact, unlike fingerprints, especially in this day and age, where we're really talking about infection prevention. So that made it attractive. And then it has high accuracy with a smaller template and a larger database. Here we're thinking, I'll contrast this with fingerprints, for example. So with fingerprints, you need, depending on the software you're using, you need at least 6 to 8 at a minimum to truly distinguish people from one another. And so that takes a lot of space in terms of how much one template occupies. And then the larger the database, the slower it becomes as your population grows. It becomes slower to run through that and identify someone once they present again. So then that makes it very slow. Give an example for those of us who engaged in the last elections. That was what was happening with the biometrics before they decided to stop using them. It takes a really long time, and especially if you're all using the system at that particular time. So with the irises, because they have a smaller template, you can have a larger database, and that speaks to feasibility. And then the cost, it's not cheap, but again, relative to other technology like retinal scans or brain EEGs, it's still more reasonable compared to those higher definition biometrics. So for our analysis, we looked at acceptability as those scanned against those approached, and for feasibility, we thought about time it takes to get the scan done, or if you're a repeat patient, to identify you the second time, and how the system performed in terms of downtime and also in terms of accuracy. And our findings were that we approached a large number of people, almost 9,000. We enrolled 8803, so about 91% declined to be enrolled. Amongst those who enrolled into the study, there are some who went ahead to decline the biometric scan. And those were very few, that's the 0.1%. Then amongst those who got the biometric scan, we still had quite a huge proportion who got a repeat scan, be they new patients or who are now linking to CCC, or CCC clients who are coming for revisits. And so in total, we had almost 16,000 scans. System issues in terms of hardware or software issues that then meant that we couldn't get an ID one way or another were affected about 1,300 people. And so total scans with an ID were about 91.5% of the whole population. So the main reasons for the decline, be it declining, and I'll focus here more on the decline of the biometric scan, because declining participation was just declining participation in the whole study altogether. Main reasons cited were privacy. So for this particular study, the camera that I showed you was attached to a laptop, and then the laptop had an internet dongle, internet modem that you could clearly see is an internet modem. And so people were scared that, their information could be leaked to Facebook or other things. I'm trying to remember the exact quotes as they said them. Again, that speaks to confidentiality and accidental disclosure. Other reasons why people decline, they said they don't have time. And then there's also the issue of shock, especially for new clients who had just turned positive. It was psychologically a bit shocking, and so they really couldn't participate. The main reasons why people actually wanted to participate, if I may talk a little bit about them. One of the key points that our counselors were using was the ability to organically move within the system. That was a really key selling point, that should this work and this is scaled up, like nationally, then they could get their drugs anywhere. That really sold this for them. Less commonly, why people were scared, there are people who thought, that the camera would destroy their eyes. There are some who already thought they had eye problems and didn't want to risk. And there, like one person talked about religion not allowing them to get the scan. And then this graph just shows the time it took in terms of being rescanned again. The enrollment visit was fairly long because of the intake form, but then the repeat visits, as you can see, just the scanning part and getting your ID was fairly short, between 1.8 and 5.8 minutes. The longer time was actually contributed to by one facility because the internet connectivity was very poor. In terms of performance, I think I'd already alluded to this. System sensitivity was about 91%. So hardware failures is really where the system, be it the laptop or the camera, for one reason or another couldn't work and we couldn't get an ID. False rejects is where the system failed to recognize a client who had already been enrolled. And that was slightly higher at 4.8, but it improved with time because the biometric reader system was fine-tuned. So initially when it was developed for Caucasian populations. And so with time, we kept fine-tuning it to the iris colors and striations and variations in color for the our African population. And then the false matches is where it would actually give you an ID that belonged to someone else, which is really critical and wrong. So those were very, very few at 0.5%, and most of them happened towards the end where the database was growing pretty huge and our server space was small. In terms of limitations, we had, as I've shown you, the system errors, and this could be improved by incorporating other text identifiers for increased accuracy. So here, we were not using any text identifiers. We were just using the biometrics, even for rescans. You would come, get rescanned, we get your ID, and we use that. We were not trying to match that with anything else. So if we used something else, then that would help. Internet connectivity. So this system, the way it was set up, it searched for you locally in the local laptop. But then if it didn't find you, if you couldn't be found in the local cache, then it would ping to the cloud server to try and identify if you've already been registered. Now for the server, that second part that I've described, that required you to have online capability. And so it would be nice if you had a system that didn't require that, or better still, if you were able to have internet connectivity, steady internet connectivity all around. And then we also had issues with ID transcription because once it gave you the number, then when you went to the CCC file, you had to transfer the number manually. So if we had a way of like a Bluetooth transfer, that would be better. So then it just links you straight to the EMR records. So in conclusion, iris recognition systems are feasible. They're acceptable, highly acceptable. We saw about 99% of the population that we approached. And remember, we approached, if you think about it from a scan perspective, every time, because we had to get the consent of a patient every time they came for a scan, that was about 15,000 scans. So it's fairly acceptable, and it can be integrated into routine service delivery. So this was being done within CCCs. It was not an outside study. We were doing this while they were coming to seek the regular services. And so if you transfer this to whatever other service you're thinking about in the UHC perspective, being integrated into routine service delivery, then biometric systems or iris recognition systems are actually feasible and acceptable. And it was also useful in improving data inaccuracies. A lot of our patients were fairly genuine, but we had about 2 where we were able to catch 2 people who posed as new testers. They were actually tested, I think this happened here in KNH Kiambu. People came to KNH, said they were new, and then went to Kiambu again and said they were new. And when they got when they scanned, it turns out they had already been tested. So what I was alluding to earlier in terms of data accuracy and use of program data for actual meaningful interpretation. So they can work. They need to be, of course, that's iris recognition systems, or essentially biometric systems. Unique patient identification is feasible, but it needs a lot of support in terms of infrastructure, advocacy, planning, and policy. And there's potential for them to be integrated into EMRs to allow for case-based surveillance. So this work was published in the journal. In terms of future interests, it seemed to capture people's interest. So these were 2 articles in the dailies, local dailies that referenced this system. As you can see, again, really, when it comes to UHC, it depends on where you're looking at it from. So one thought about it as a biometric system for identifying people living with HIV. There can be a bit of stigmatization with that. Another one thought this system would be able to save hospitals money. What we're talking about, accountability, depending on the angle that you want to view this. In terms of where else the system is used, it's currently used for in a couple of studies that are actually involving people who inject drugs. I also know that the national programming for key populations, they're not using irises in particular, and they're still using fingerprints, but they do use biometrics for unique patient identification in their programming. And with that, let me acknowledge my funders, the participants of this study, the administration for all those hospitals, and also the county level industry, because I respond, the developers of the system give us the system for free, as well as colleagues and friends who helped with this study. Thank you.
Thank you very much, Dr. Anjarog. And wow, indeed, a lot is being done out there, even amongst ourselves. And it is like, this is a really good platform to actually disseminate and know what is happening around. And I believe this is feasible and scalable. However, there's a question from an anonymous attendee, and it's a question that I think most people are wondering is, are there factors in relation to eye conditions that affect these, the iris tracking? Any eye conditions that might cause this not to work. And I know that was part of the fear that people had as you what you were saying in terms of the barriers. So we're wondering, is there any eye condition per se?
Right, thank you so much for the question. Are there eye conditions that are a barrier to this? Yes. If, for example, for the people who don't have an eyeball for one reason or another, and so the eyelid is shut close, then you're not able to use the current cameras that we were using. What I didn't mention is that the cameras that we were using are we chose those ones because they're fairly hardy. They actually were used in the last general elections in India. That's what they used. So that's why we went for them. The matching is enhanced when you use both irises. And so for people who don't have one eye for one reason or another, it's not that you cannot use the one eye that actually works. It's just that then that reduces the system accuracy in terms of being able to identify someone uniquely. In terms of other conditions, unless you have scarring of the iris, because we did have people who reported, there weren't that many, there were like 2 people who reported having had previous surgery for retinal detachment, but it still worked. So it's basically conditions that then only affect the iris. Like if you have iris scarring for one reason or another, then you wouldn't be able to use the system.
Thank you very much for that response, and I think it answers the question that was asked. I think maybe just for me, I'm trying to figure out like how accessible is it to get this material, especially here in Kenya? Is it something that can be gotten while here, or is it something that's for importing? Is it is it easily trainable? Like you can train someone such that it can be implemented large scale, not just for HIV programs, but for all programs?
Yes, it is. It's something that can be scaled up. So I think in Kenya, we are very innovative in terms of the things that we're able to develop. So in terms of the system, while we used this, which is a proprietary system by that company, I do believe that we do have the resources to be able to develop our own system. What I can say we would, at the currently we would need to import is probably the cameras, the scanning cameras. And again, by then when we were doing this, this technology was not as widespread. So now it is. So then we were importing. It was fairly expensive because one camera was costing about $450 USD. But then that cost has now gone lower given, I mean, the cost has come down significantly given that other technology companies are investing in this. So there was a time we wanted to scale this up and were having discussions with Huawei, who are actually trying to get this done, but through the smartphone technology, which would then make it way more cheaper and way more accessible. That ran into challenges because the cameras that the camera specifications that can go into a tablet or a phone, if you're packing other features into that phone or tablet, you have to compromise a bit on the quality of the camera. So that became a challenge, but at least it shows that it's actually possible. So Is it something that can be scaled? I do believe that it is. Looking at some of the other questions that I am seeing, how feasible is it for all the people living with HIV to be enrolled using system, and what implication would it make to donor-funded projects when the numbers turn out to be lower than actual numbers? That's a very interesting question, Anthony. That has always been an issue, especially when it comes to donor-funded projects, because if they're based on numbers, anything that's based on numbers is fairly sensitive. That's more of a political question. Feasibility and acceptability, I think we can say they are. Politics behind how acceptable that can be, given that it has implications on funding and other ramifications. I would draw a parallel to the elections. I guess there's political reasons why it's also, biometrics don't work as well during such sensitive times, because then if you're able to identify unique people, you would not have dead people voting and things like that. So yeah, I guess it's more of a political goodwill that's lacking in such an instance, as opposed to whether the technology is available and whether it's feasible and acceptable to that population, particularly where we thought that because of stigma, then that would be a barrier, but it turns out perhaps not as much.
There's a question here from James Amenge, whether the contact lenses affect the quality, and what's your view in its application in the general healthcare system, cost, acceptability, and sustainability issues. I know right now a lot of people are moving away from contact lenses. So what happens if the participant or the patient does not tell you that they are wearing their contacts or something?
Right, very good question, James. Thank you very much. Does contact lenses affect the quality? Yes. So like for this particular study, we would request the participants who, again, in our setting weren't that many, but yeah, they needed to remove the contact because the reflection on the surface of the contact lens does have an impact on the quality of the image. My view in its application in our general healthcare system, I think we won't have a choice. Quite frankly, with time, we're going to have to embrace biometrics one way or another. Maybe not iris scans, but whether they be fingerprints or footprints for the very young children, we're going to have to go that route, because you see, if it's being adopted as the way to go, for example, with this Huduma National Integrated system, the NIM system, we will not have much of a choice as the healthcare sector. So it's feasible, it's acceptable, it's not cheap, I must say. But that's just the startup costs. As with anything else, the startup costs could be fairly expensive. We thought that we couldn't do electronic medical records. Look where we are now. We're also moving, towards the integrated. Initially, we started with the HIV records. Now we're moving to the National Electronic Health Record System, the EHR, that will hopefully be rolled out soon. So yeah, it's feasible, it's acceptable, it's possible, and in the long run, it will be sustainable. There's a question from Dr. Kinyari. Is it possible to use it among aged less than 10 months? I said for 10 kids below 10 months, it's tricky because below 10 months, their irises can still change in terms of the striations. So then it would not be possible to uniquely identify them as they grow older. So the option of either using the caregivers or another identifier for that one, I think people use, in other settings, people use the footprints, that both footprints. There are challenges with that as well. In underage, the ethical consideration using this method in underage clients. So again, when it comes to unique identification, once we embed it in the system, it's about, you know, being able to identify you, not because given the level of access, depending on the level of access, then the issues of ethics really don't come in terms of records, because it just uniquely identifies you. It doesn't necessarily mean we have access to your records. So we know it's being rolled out, like the school systems now, they're using the biometric package for their fingerprints when they're enrolling people in class 1, and that's required. So I think the main issue there is more of the legal and policy framework around it being universal when it comes to coverage, because it has to be, for it to work, it has to be universal. It has to be everyone, and not about whether you want it or not. Nancy, I don't know if there are other questions that I may have missed.
I think you've addressed all the questions. There's no question that's left pending. Thank you very much for your presentation. It's really good to see what is happening even within us and the ideas that we are having. Maybe your parting shot even as we come to the end of the session.
My parting shot would I know there's a lot of debate out there in terms of use of biometrics for patient identification and the stigmatization that comes along with it. But I hope I have convinced you that when it comes to biometrics, really, unless that is linked to another piece of information, using biometrics in and of itself cannot really lead to accidental disclosure of information that you did not want disclosed. Case in point, for example, there's this debate about, you know, using this system for people who have people who inject drugs, and how that can be used to you know, get them arrested, since that is, you know, something that's against the law. But then again, if the fact that I have your 10 fingerprints, unless, you know, the police access, you know, your fingerprints, and then they go and tap into the system where they can see who this is, how old they are in terms of their names and gender and all those that other information, with just the fingerprints, even if they came into, you know, into the wrong hands, so to speak, they cannot be able to deduce anything unless it's linked to other information. And so I think moving forward, we need to keep that in mind, even as we are being asked to register for, you know, the Huduma number. And there's all these questions about all the other information that they are collecting. I think that that can be debated, but the biometrics piece, at least, is very, it can stand out by itself and be useful for authentication and unique identification without linking to any of your other information that would then need to remain private. So biometrics are important. They're useful for unique identification. They are feasible, acceptable, and they're the way to go moving forward. Thank you.
Thank you very much, Dr. Anjoroge, for taking your time to actually present to us the innovations that we are having even within us. So we've come to the end of today's webinar, today's afternoon webinar, but we'll be having another webinar in the evening from 7 p.m. to 8:30 p.m., where we'll be looking at the clinical presentation, diagnosis and staging of breast cancer. Remember, we're in the month of October and it's Breast Cancer Awareness Month. So how do we pick out the early signs of breast cancer and be able to fight breast cancer? And we'll be doing this from 7 p.m. to 8:30 p.m. For everyone who still has issues with CPD, kindly email us at knetcpd@gmail.com. Otherwise, have a very good evening, afternoon, and let's meet in the evening. Thank you very much.